All right, so this is the ACLS high yield, and basically I'm going to be talking through the pamphlets that come with the ACLS Advanced Cardiovascular Life Support manual. And I'm learning as I'm going through this. I learn best by talking things out, and that's why I'm doing this. So some of these are pictures I took and some of them are scans. So here's the first little picture that they have on the manual. And this is supposed to be a circular algorithm for cardiac arrest. And you see, first thing you're supposed to do is you're supposed to shout out for help and activate the emergency response. And the reason for this is because CPR mostly just kind of keeps people's brains from dying. In order to really get people to live, they're going to need to go to a hospital most likely. So this is what you do to get the people that are going to be able to really save their lives to show up. In the meantime, you need to keep this person's brain alive. And in order for brains to live and not become ischemic, they need oxygen. And so you're going to start CPR. And CPR is transitioning between breaths and chest compressions. So if there is a monitor or a defibrillator there, basically what it is these little sticky pads, and you stick them on certain places on the person's chest, and it will, depending on what kind it is, it should monitor the basic rhythm of the person's heart, if they don't have a rhythm, or if it's fast or slow, whatever. And then based on what kind of rhythm it picks up, it's going to administer a shock at appropriate times. And so you're giving the person oxygen, which means you're giving them breaths, and you've attached this monitor. And this little thing here is going to check the rhythm. And this VF and VT stands for ventricular, goodness, I just forgot now. Ventricular tachycardia, or I don't remember what the other one stands for, goodness gracious. Anyway, for one of those indications, it'll give a shock. And immediately following the shock, you'll continue with the CPR. And you're going to be monitoring the quality of the CPR, and then you're going to be doing more CPR. And there's an option in here for drug therapies. So you can give intravenous IO access of epinephrine every 3 to 5 minutes. And the purpose for that is epinephrine is basically, it's like puts a big jolt, kind of jolts the heart going again. And what you're trying to do is try to get this person's heart going. Because the whole reason you're doing this is because they had cardiac arrest. Arrest means stop. Like when you're going to arrest somebody, you're going to stop them. So the heart has stopped. So epinephrine can kind of jolt that heart back into going. Also, there's amiodarone for refractory ventricular tachycardia. And basically, this means your heart's just sort of like shaking. It's almost like having a seizure. It's not really doing anything. As far as pumping blood, it's just kind of sitting there shaking. And the amiodarone, I believe, kind of slows it down, or gets the appropriate levels of, I think it's potassium is what this one works with, but I'm not positive off the top of my head. Also, you need to consider advanced airway. Capnography is a way of monitoring the carbon dioxide that's taking place in the person. And then last, you need to treat the reversible causes. So that's the first cardiac arrest circular algorithm. Now I'm moving on to the second one here. And for this cardiac arrest algorithm, what we have is this one, rather than being circular, this is showing more of a diagram. And so the first thing you do, again, this is a repeat, is you shout out for help or you activate the emergency response so that you're going to get the people from the hospital to show up. And then you can go ahead and start the CPR, just like I said before, which is giving oxygen, attaching the monitor and defibrillator. And at this point, the little machine, the defibrillator monitor is going to say whether a shock is advised or not. So this is showing out here a rhythm shockable. So, for example, if the person is in asystole, maybe it wouldn't be, versus a VF or VT, it might be. So if it is shockable, it means they have a VF or a VT, and if it's not shockable, it means they're in asystole or PEA. So let's go down the algorithm of no. Let's say it's not shockable, because this one's a little bit more simple than the other one. So let's say it's not shockable. The person's in asystole, which means it's not beating. Then what you're going to do is you continue CPR for 2 minutes, and then you can give the person so it's IV/IO access. Then you need to give them epinephrine every 3 to 5 minutes, and consider advanced airway capnography. So this is basically measuring to see if your CPR is effective. It's gonna check to see the CO2 levels, and if it is, again, it's going to monitor the rhythm, and then you ask the question again: is the rhythm shockable? If no, you just continue CPR 2 minutes, and then treat reversible causes, whatever it may be. And then again, is the rhythm shockable? And say no. Well, if there's no signs of return or spontaneous circulation, which is what the ROSC stands for, then go to 10 or 11. So you're going to repeat this 10 or 11 times. And then if there is a return of spontaneous circulation, then you need to go to the post-cardiac arrest care. So we're not at that point yet. So we just went through the worst case scenario where it was a no on everything. So let's go back here to an instance where we went down the same algorithm, except for after doing CPR further, the rhythm was shockable. It says go to 5 or 7, so you repeat this 5 to 7 times. So now going back here, coming back to the very first time when you first see them and the person's in cardiac arrest and you've given them oxygen, attached to the defibrillator, and if they're in a VF or VT, that means that the rhythm is shockable. So you shock them now, and you're going to continue CPR for 2 minutes, and then you're going to check again, is the rhythm shockable? If the answer is no, then we go back down here where we saw before, where you just basically repeat this 10 or 11 times. If it is shockable, then what you can do is CPR for 2 minutes, and epinephrine every 3 to 5 minutes. Consider advanced airway capnography. Again, that's measuring the CO2. And then you just keep on going through the same algorithm. Is it shockable, yes or no? If it is shockable, at this point, it looks like you've administered 1, 2, and 3 shocks. At that point, if they're still in cardiac arrest, then you're going to consider giving the person some amiodarone. So you've done CPR 1, 2, 3, 4 sessions of CPR, and they've had 1, 2, 3 shocks. At that point, you give them amiodarone, and then again you see if the rhythm is shockable, and you can just kind of repeat that. So that is the algorithm to follow there. So earlier we said, if the person does resuscitate, then we can go into this, which is called return of spontaneous circulation. So earlier we were saying there was cardiac arrest where their heart stopped, but now their heart is going again. So they call that return of spontaneous circulation, or ROSC. So let's say we were successful. The person's heart is going again, and they now have circulation. So this is what you do. So you want to optimize the ventilation oxygenation, which is going to mean that you're going to maintain the oxygen saturation above 94% and consider advanced airway and waveform capnography. Do not hyperventilate the person. Okay, you don't give them too much. So basically, they're back. Well, they've probably been without adequate oxygen for a while. So what's the first thing you want to do? Is give them oxygen. Make sure they're okay. Give them some oxygen. Okay, so their oxygen's coming back. Well, their heart, maybe it's really tired. Maybe it's not pumping right. So likely they have hypotension after just coming back out of cardiac arrest. Now they're in the ROSC, and you want to treat this hypotension. Well, how can you treat hypotension? Well, one big way is just give them fluids. It's sort of like if you had a series of pipes and the pressure wasn't very high in the pipes. If you want to increase the pressure in the pipes, put more water in the pipes. It's going to increase the pressure. So that's this IV bolus. Another thing you could do is you can make the pipes smaller. That'll make it higher pressure. So that's what this vasopressor does. You can give a vasopressor, make the pipes a little smaller. I heard that there was some changes on this step, but we won't worry about that now. Other thing is to consider treatable causes. So yeah, don't worry about that. And then, of course, applying a 12-lead ECG to see what's going on. Electrocardiogram. EKG would be the German form. Now, they follow your commands? Tell me your name, or whatever you ask them to do. Can they listen to you and respond? So if they can't, let's go with the worst case scenario here. Then you want to consider induced hypothermia. So hypothermia. I hope I said that right. So basically, induced hypothermia is where you, if I'm understanding this correctly, is where you basically get them very, very, very cold. And what this does is it decreases the oxygen blood demands for the whole body, and gives you some time to be able to perform surgery on this person, as they probably need surgery. If they've come out of this and they can't do anything, put them in hypothermia may give you some more time. And then after inducing hypothermia, then you can look into the STEMI or high suspicion of AMI. I don't know, maybe this was, I won't worry about that. So the other thing here is if you ask, if they can follow your commands and the answer is yes, then you would, I guess, immediately consider this. I'm wondering if maybe this box isn't meaning that you induce hypothermia on them, or maybe it's meaning instead that you're wondering if they have hypothermia. I'm really not sure here. I don't know what they mean exactly by that. Hopefully reading the thing on the side may give me more clues, but either way, recognize that something with hypothermia has to do with their inability to follow commands. Okay, so now STEMI or high suspicion of AMI. If the answer is yes, that is a STEMI or AMI, then you're looking here at coronary reperfusion, okay? And either way, if it's no, then you still want to do advanced critical care. So let's look at this little thing on the side here. This gives us, in order to pass the ACLS, you're going to need to know some doses and that sort of thing. So let's look at some of the details and doses. So first thing here, it says ventilation and oxygenation. You want to avoid excessive ventilation, so you don't want to give them too much oxygen. You want to get it right about there, just above 94%. So avoid excessive ventilation. Start at 10 to 12 breaths per minute. So that means every 6 seconds or so, you should be giving the person a breath, 5 or 6 seconds. And titrate, target PET-CO2, this is like their carbon dioxide levels, of 35 to 40 millimeters mercury. So you want the 35 to 40 with 10 to 12 breaths per minute. When feasible, titrate FiO2 to a minimum necessary to achieve SpO2 greater than, this is oxygen pressure, greater than 94%. So basically you want to keep this person above 94%, giving them 10 to 12 breaths per minute, and you have that capnography thing, then you can get the PETCO here, PET-CO2, and you want to get that around 35 to 40. All right, what about this IV bolus? At one point we mentioned here IV bolus. So this here was talking about this step. So now we're talking about the IV bolus. Well, what exactly is that? Well, 1 to 2 liters of normal saline or lactated ringers. These are just different types of solutions of IV bolus. If inducing hypothermia, may use 4 degrees Celsius fluid. So if it looks like you are trying to possibly induce hypothermia, that's what this step is, just what I originally suspected. So if you are inducing hypothermia, you want to get the fluid a little bit colder. I'm not familiar with Celsius very well, but I'm assuming that's what that means. Epinephrine IV Infusion. So this was actually looks like a step from the previous slide. So let me go back here. Here on the previous slide, we said, after doing, original shock, or I guess even if we don't do a shock, if it doesn't work, if we're trying to get their heart start, they're in asystole, or if their rhythm is shockable, but we've shocked them twice already and it's still not working again, we're supposed to administer epinephrine every 3 to 5 minutes, try to just get their heart started again. So epinephrine infusion, IV infusion, 0.1 to 0.5. So that's a very small amount. At most, you put in half mcg per kg per minute. Oh wow, 3 to 5 minutes, but whatever. Maybe that just means a drip or something. In a 70 kilogram adult, 735 mcg per minute. Okay, so there's a specific ratio you need here, but about an average weight adult, I think it's like 140 pounds or something like that. You want to give them about 7 to 35 mcgs per minute. So then we have here the dopamine infusion. And I haven't seen anywhere, I'm not recognizing any place where there was a dopamine infusion, but apparently at some point in time we're going to be considering a dopamine infusion. Looks like if you do that, it's a 5 to 10 mcg per kilogram per minute. And later on we cover a norepinephrine IV infusion. And right now I'll just say it, 0.1 to 0.5. So looks like the same as the epinephrine. Dosing here is identical with the epinephrine. And then the reversible causes. So in one instance back here it says consider treatable causes, and over here it said treat reversible causes, and here it said treat reversible causes. So what are some of these reversible causes they're talking about? Well, it could be hypovolemia. Maybe their heart stopped because they lost all their blood and their heart became ischemic and stopped. Maybe another reversible cause is they have hypoxia. In other words, not enough oxygen. I heard of a case of somebody who climbed down into a fuel tank and there was no oxygen in there, and they died. So, I mean, that would be an instance where you want to get them out of there so they can breathe. Hydrogen ion acidosis. Hypo or hyperkalemia, hypothermia. So basically here, these are all just pretty straightforward things that would make sense to stop things here. Too cold, too much potassium, too much acid, not the drug kind of acid. Tension pneumothorax, tamponades, they got a bunch of blood around their heart, toxins, thrombosis, pulmonary thrombosis. I mean, they got the blood clot in their lungs, or they've got a blood clot in their heart. These are all possible reversible causes, and we'll talk about some of these later, like the fibrinolytics to get rid of some of those thromboses. But I think that's a good review of what we got so far. So what about if they have a pulse, but they have bradycardia with a pulse? So what do you do? So bradycardia is where the heart is beating very slow. And they said the heart rate is typically less than 50 beats per minute. So if you look here on this thing, you're like, well, how many little bars is that? There's a little way of measuring this where you go, here's where the little heartbeat was, or the electrical impulse, and then you count, and it's kind of weird. You go like in half, so you sort of in half. It gets weird. So it goes 300, 150, and then it just kind of keeps going by half. So you see this is a very slow heart rate. So yeah, 300, 150, 75, and then it just kind of goes down. I don't remember all the other ones from there, to be honest with you. I think actually it goes from 150 to 100, and then 75. I don't remember. I'll need to pull it up, to be honest with you. I can't remember off the top of my head. It's been a little while since I covered cardiac section. Kind of embarrassed that I don't remember that. Anyway, so coming back here, heart typically less than 50 beats per minute if bradyarrhythmia. So first of all, the thing you want to do is identify and treat the underlying cause. So remember we talked about some of those underlying causes for cardiac arrest. Well, there's also underlying causes for bradyarrhythmia. So you want to make sure you treat the underlying cause. So maintain a patent airway, which means you want to keep their mouth and their esophagus, their breathing, the whole pathway there to their lungs open. You have to tilt their head back and whatnot. Assist breathing as necessary. I mean, you might have to give them some puffs, and you may need to give them oxygen if hypoxemic, if they don't have enough oxygen. Cardiac monitor to identify the rhythm, and monitor blood pressure and oximetry. IV access, it's always good in case you need to. It's intravenous access in case you need to give them some sort of medication. And then 12-lead ECG if available, but don't delay therapy. All right, so now that you've identified and treated the underlying causes, and they've got oxygen and monitors and all these things all set up, now you want to, it's saying the persistent bradyarrhythmia. So you've gotten rid of these possible causes, or maybe there wasn't any. You want to think, well, is there hypotension? Are they acutely altered? Is there acutely altered mental status? Are there any signs of shock? Is this ischemic chest discomfort? Any acute heart failure? All these things could be possible things that could be associated with problems that would cause bradyarrhythmia. So if there's no, they don't have hypotension, there's no shock, there's no altered mental status, they're fine, everything, we'll just monitor and continue. You've got all these things, watching them carefully, their oxygen and everything like that. So just watch them and wait to see what happens. You don't need to rush into anything. It may just resolve on its own. But if they are hypotensive and they are in shock and they have an altered mental status and there's acute chest discomfort from ischemia, or maybe they had acute heart failure, any of these sort of things, what do you want to do? Now it's time to administer atropine. So atropine is another one of those medications. And if atropine is ineffective, it says try transcutaneous pacing, or you can give them dopamine or epinephrine. So back here we were looking at the dopamine doses. Dopamine was 5 to 10. And remember, norepinephrine and epinephrine both had the 0.1 to 0.5 mcg per kilograms per minute, or in adult 7 to 35. Okay, so you give a lot more dopamine than you give epinephrine or norepinephrine. So there it said you can give any of these drugs. It didn't mention atropine on this list, which is unfortunate as far as the dosing, but that's okay. Looks like it's right here. So now if you try these things, consider an expert consultation or transvenous pacing, whatever. So let's look here at the dosing of atropine. So the first dose looks like a 0.5 milligram bolus, and you repeat that every 3 to 5 minutes. The maximum of 3 milligram or mg. So the dopamine infusion looks like it says 2 to 10. Is that the same thing it said over here? It says 5 to 10 over here, but whatever, close enough. And then epinephrine, it says 2 to 10 per minute, and that's different than what it said over here. So it looks like if a person's heart has stopped, it looks like you give them a bit more epinephrine. Maybe 3 times as much epinephrine if their heart's completely stopped. And with the dopamine, it looks like you give them possibly a little bit less dopamine as well, possibly half as much dopamine. So bradyarrhythmia is not as serious as a complete heart stop, so you give them less medication. That'd be a good general rule to observe here. It looks like you don't give atropine at all if their heart stopped, but it looks like you do give atropine if their heart is slow, possibly. Drugs, I think I've covered the rest of them. It seemed like there was one I was missing, amiodarone. It looks like you give amiodarone possibly in the case of cardiac arrest, but it looks like you do not give amiodarone in the case of it returning, or if they have bradycardia. So atropine for bradycardia. All right, now what about tachycardia? So sometimes the heart beats so fast that it's not effectively getting blood to where the blood needs to go. In a case like this, then what you need to do is you need to first assess appropriateness for clinical condition. Heart rate is typically greater than one, so if it's tachycardia, it's going to be greater than 150 beats per minute if it's a tachyarrhythmia. So first thing you're going to do after you see, is this appropriate for me to jump in here and is above 150, I kind of showed an example. Look at this, there's practically a beat every one of these little bars. It's really fast. That's like this is like 300, or close to 300, probably more like 280 or something like that. And remember, the way I know that is I go from here, from a spot where it's right on the line or really close to the line. I remember it goes 300, and then it would go 150. So this is somewhere between 300 and 150. So maybe 2 something, I don't know, or 190. All right, so now that I've determined what it is, I identify and treat the underlying cause. So with everything, sometimes there's just underlying causes. So maintain patent airway, assist breathing. They call this the ABCs, airway, breathing, and circulation. Although recently they've been calling the CBAs, the circulation, breathing, and airway, because they say circulation is more important than the airway. So I always check the ABCs first. Give them oxygen if they're hypoxemic, and cardiac monitor to identify the rhythm. Monitor blood pressure and oximetry. So take care of those ABCs first. It's pretty much always going to be the first thing you do. Now let's say that you do that stuff and they still have tachyarrhythmia. So you want to think, well, what is the cause? Do they have hypotension? Is that why? Sometimes when a person loses lots of blood, their heart is going to try and beat really fast to compensate for the fact there's no blood. Okay, and that, maybe helps a little bit, but wear your heart out. Acutely altered mental status, or there's signs of shock, or is there ischemic chest discomfort or acute heart failure? These remind me a lot of the underlying causes for bradyarrhythmia. Let's say the answer is no. Well, is there a wide QRS? Okay, so the QRS complex is essentially right here. Q, R, and S. And this is a really narrow QRS. And here's another one here. Q, R, S. And you want to see, that looks pretty narrow to me too. But if it was really wide, QRS, then you're going to suspect something. It says greater than 0.12 seconds. So I'm trying to remember here, I think every one of these little things here is 0.04, I believe. So 3 little boxes, I think, is what it is. I really need to review that again. But 1, 2, 3. This is like only 2 wide. This one here is like 1, 2, 3. This is about 3. So it should be about 3 or 4. So if it's greater than 0.12 seconds, which is the same as like 3 or 4 little boxes, then you're going to say, okay, if yes, then you need IV access and 12-lead ECG available. If available, consider adenosine only. Okay, that's interesting. If regular and monomorphic, okay, so if it's regular and monomorphic, excuse me, I said that really weird. If it's regular and monomorphic, okay, then monomorphic means just the same pattern, and it's beating the same pace. Then you're going to think, oh, let's think about some adenosine here. Give them some adenosine. Adenosine, essentially, if I'm remembering correctly, it pretty much just stops the heart for a little bit, and then the heart starts again. And sometimes that process of just stopping the heart and starting again, it's almost like shutting off your computer and resetting it. Sometimes for some weird reason it'll just work right. So that's if it's regular and monomorphic. So if it looks kind of like this, see how this regular being, it's really fast, but it's beating the same kind of point, same spaces, like every little thing, like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. It's like every 10, it's like 10 little boxes, 10 little boxes, 10 little boxes. And here, monomorphic, there's nothing weird. There's not like a tall one and a really short one and like a weird long one. They're all the same size, look, and everything like that. So in this case, you'd probably give adenosine. So if it says consider anti-arrhythmic infusion, so anti-arrhythmia drugs, I believe that would be an example like amiodarone. So you consider that, and you also want to consider expert consultation. So that's if you've got a wide QRS, apparently. So what if you have do you not have a wide QRS? You have a normal QRS or a narrow QRS. In that case, you want to get IV access and 12-lead ECG if available. Consider vagal maneuvers. So vagal maneuvers, you basically have this nerve called the vagus nerve, and it runs down through your neck, and you can mess with it by pressing places on your neck, and you can also do something called the Valsalva maneuver, which is basically you act as if you're going to poo, but you don't really poo, and it like puts a bunch of pressure on there. And if I'm remembering correctly, that could be considered a vagal maneuver. If I'm incorrect there, I apologize. And that can sometimes kind of reset things and slow things down. Also here, adenosine, if it's regular. So it looks like you only use adenosine if it's irregular. Also consider beta blocker or calcium. Beta blocker slows the heart down. Calcium can have the same effect, or a channel blocker. Okay, so it looks like there's a lot of options here. So calcium channel blocker, and consider expert consultation. So if the person's got a regular beat, give them adenosine. If they have a wide QRS, looks like also probably adenosines here. As long as it's regular. The difference here between these two, with the wide QRS and non-wide QRS, is it looks like in the case of a wide QRS, it looks like you're giving them an anti-arrhythmic, but if it's not a wide QRS, it looks like you're giving a beta blocker or calcium channel, and also considering like a vagal maneuver and something like that. Looks like the main difference between these two is just this one I'm seeing. Both of them seem like they have adenosine, as long as it's a regular with a wide QRS. But in the case of, I'm repeating myself here, in the case of a wide QRS, the difference is that you give them a anti-arrhythmic, whereas here you give them a beta blocker or calcium channel blocker and vagal maneuvers. So what if we go up here, and in this case, the person comes in, they've got the tachyarrhythmia, you do the underlying cause thing, but they still have it, and you're looking to see, is it hypotension, any of these things, hypertension, acutely altered mental status, signs of shock, ischemic chest discomfort, acute heart failure. If any of these ones is yes, then you're going to consider something called synchronized cardioversion. So a synchronized cardioversion is basically, it's like they use the machine to give certain shocks to try to like get the heart back into its regular rhythm that you're trying to go for again. It's kind of like shocking the muscles back into their regular flow. And so you want to consider sedation because it's extremely painful, like horrible. And also if regular, narrow, complex, consider adenosine. So again, you only give adenosine if it's regular, okay? In this case it says regular, narrow. So it's a little bit different here. All right, so I think we've gone through this whole algorithm pretty well. Now what we're looking at is what is synchronized cardioversion. So it says here for doses and details, for synchronized cardioversion is the initial recommended doses is a narrow, regular, 50 to 100 joules. So narrow and regular. So this is talking about the narrow, the QRS, that little QRS, narrow, okay. And a regular, well, here we go, regular is just the same every time, 50 to 100 joules. That should do the trick. Now what if it's narrow and irregular? So like some are high and some are low and some are long and some are short. That's a little weird. We got to really shock this thing. So we're going to up the heat here. 3 times more almost. So 2 to 3 times more. So 120 to 200 joules if it's irregular. I really want to shock the irregular situation. That's if it's biphasic. If it's monophasic, it looks like you just go straight for the 200. Monophasic or biphasic, I'm not going to go into that right now. I don't fully understand it myself, but I think most of them now are I can't remember now what the doctor said the other day. Oh well, anyway, don't worry about it. Wide regular, 100 joules. So this is if the QRS is really wide, then you just go for 100. And if it's wide and irregular, so there's like odd spacing and heights and weird things like that in here, and also the QRS is wide, then we're going to be looking here saying the defibrillation dose not synchronized. So you don't do it. I think that's what they're trying to say. What about adenosine? So, and here almost every single option we were considering with tachycardia, adenosine, as long as it's regular. If regular, adenosine. If regular, adenosine. If regular, adenosine. So in every case, if it's regular, you're going to use adenosine. So how much adenosine do you use? Well, the full first dose is 6 mg rapid IV push. So you just shove that in there to stop the person's heart. And it says narrow, follow with NS flush. And then it says second dose, 12 if required. So if you try to stop their heart the first time, you give them 6 mgs, doesn't do the trick. Well, next time, double it. All right, so now we're going on here to anti-arrhythmic infusions for stable wide QRS tachycardia. So let me say that again. Anti-arrhythmics. So where was the anti-arrhythmics? Over here. Remember, if the person had a wide QRS and a tachycardia, and you already looked at all the underlying causes or whatever, wide QRS and tachycardia, anti-arrhythmics. Remember, it was the narrow QRS and where you were considering giving adenosine, beta blocker, those sort of things. Over here, this is the wide QRS, so anti-arrhythmics. So this is for stable wide QRS tachycardia. So what drugs do you give? I thought maybe amiodarone, but the first one on the list here is procainamide. That's another one of those. I think this one may also block potassium. I can't remember what this one blocks. Maybe it's sodium. But anyway, they block either like sodium, potassium, or one of those things like that. One of those electrolytes in the body. So it says the procainamide IV dose is going to be 20 to 50 milligrams per minute. until the arrhythmia is suppressed. So every minute you give him 20 to 50 mgs per minute. Wow. Okay, and if the hypotension ensues, in other words, if it goes from a normal pressure to being really low pressure, maybe high pressure, low pressure, you want to do this until the arrhythmia is suppressed, hypotension ensues, QRS duration increases. In other words, the reason why you're doing this is because the QRS complex was, it says a wide QRS. So what you want to do is, it says here, QRS duration increases greater than 50%. Okay, interesting. It means if it starts lasting longer, I guess you'd stop. Or maximum dose, 17 milligrams per kg given. So you can't give them too much. You don't want to give them over the 17. Which is odd because this probably depends on their weight here. So this would be actually a ton, because they probably have, probably, I think 70 kilograms is a normal person. So 70 times 17, that's a lot. Maintenance infusion, 1 to 4 milligrams per minute. So you might just give them a little bit, and avoid of prolonged QT or CHF. Okay, congestive heart failure or QT. So QT is there's the right here is the they call it QRS, and I think it's like space after that or something. Maybe it's from here to here. All right, so now amiodarone. So this is the other drug that we're going to give. This is the one I was originally thinking of. So the amiodarone dose. The first dose is 150 milligrams over 10 minutes, and repeat is needed if the ventricular tachycardia recurs. Followed by maintenance infusion of 1 milligram per minute for first 6 hours. Sotalol IV dose also 100 milligrams. This is another one. Sotalol, I heard you have to monitor them a lot. Use potassium, but 100 milligrams, 1 to 5 milligrams per kilogram, over 5 minutes, avoid of prolonged QT. So here's a lot of dosing, stuff like that. Hopefully you get that down. It is a little confusing to me as well, so hopefully you can figure that out. Maybe you want to pause and write this down, memorize it. But let's move on. So so far, quick review. We did the circular cardiac arrest algorithm, then we did the cardiac arrest that was not circular, then we went to, and this is just the way it's showing, there's just different ways of showing it. And then here we have the immediate cardiac arrest care algorithm. So this is when they're right after they had cardiac arrest, but now they have circulation again, what we did. And then we went from there to bradycardia. So that's just a slow heart. And then we went to tachycardia. This is a fast heart, and they do have a pulse in both these instances. And now we're going to suspected stroke. So if somebody comes in, we think that they had a stroke. What are we going to do? I'm actually going to stop this video here and pick us up on the next one. So make a part 2 out of this. I hope this has been helpful for you.